I'm very pleased to introduce Dr. Christopher Bowling. He is a pediatrician and partner with Pediatric Associates in Crestview Hills, Kentucky. He is a volunteer associate professor of pediatrics in the Division of General and Community Pediatrics at Cincinnati Children's Hospital Medical Center and the University of Cincinnati College of Medicine. Dr. Bowling serves as the chair of the Executive Committee for the American Academy of Pediatrics section on obesity and is Obesity Task Force Chair for the Kentucky chapter of American Academy of Pediatrics. Dr. Bowling completed his pediatric residency and chief residency at Cincinnati Children's Hospital Medical Center and is certified by the American Board of Pediatrics. Published in the area of behavioral and primary care pediatrics, Dr. Bowling serves as a consultant in matters related to obesity, prevention, motivational interviewing, community-based participatory research, quality improvement, public policy, and practice-based research. He also speaks on and trains providers in public advocacy and has extensive experience in early child obesity prevention in the medical home and child care settings. Dr. Bowling was the Kentucky State Lead for BR Voice, a program to train medical providers to be advocates for obesity prevention. He is the former president of the Northern Kentucky Medical Society, the Cincinnati Pediatric Research Group Practice-Based Research Network, the Cincinnati Pediatric Society, and the medical staff of the Cincinnati Children's Hospital. We are so very delighted to welcome Dr. Christopher Bowling to our Key to Hot Topic webinar, and you may have seen him in the Motivational Interviewing webinar that is part of this module's webinar series. So with that, I will pass it over to Dr. Bowling to present on creating a supportive office environment to effectively manage obesity.
Great. Thanks, Renee. Let me see if I can go ahead and advance the slide here. Let's see. There we go. So basically, like I say, the topic is creating a supportive office environment to manage obesity. But it's really about using, as you may have noticed from the article that I sent you guys, a lot about the topic of weight bias or weight stigma, which is something that I think we hear about, but we don't have a chance to really talk about very much or a chance to really delve into very deeply. But I think it's really important if you're going to be effective with your patients to be able to really talk about these issues in an effective and a supportive sort of way. Let's see, I'm having a hard time advancing it here. I'm not sure if I'm using the, oh, here we go. There we go. So what is weight stigma or weight bias? It's really, if you define it, it's really the societal devaluation of a person because he or she has overweight or obesity. It can really manifest itself in a lot of different ways, and it's also frequently accompanied by some negative stereotypes. You know, one of the things that I've gotten out of the habit of doing, I used to do a lot of, you know, what I thought were humorous sort of cartoons about weight loss, et cetera. I've really gotten away from those because I think those especially tend to play up or tend to trivialize or tend to make fun of weight status, which is something we're really trying to get away from, something that really kind of gets in our way as providers. So why should we worry about this? I think there are a lot of reasons to worry about it. Number one, see, if I can get this to go here. There we go. It's really the right thing to do. You know, we're talking about being kind to our patients. We're really trying to be respectful of them. It's just a way of speaking and hopefully a way of interacting with our patients that doesn't manage to kind of stooge ourselves before we even get started with them. We're going to be having some very difficult conversations on a lot of different issues, and I think if we are not being very respectful with our patients, they're going to turn us off. So I think it's also really a smart and a very time-effective thing to do as well. If we wind up hacking our patients off from the very get-go, and we might be doing it unknowingly, we're just going to be fighting to try to get back on track with them for a long period of time. So I think it's really also a little bit about being time effective. When you're thinking about this in the four processes of MI, and I was glad Renee and Sam brought up the motivational interviewing piece of this, this really is, we're talking about that first process of MI. If you remember, there are sort of four steps: engaging, guiding, evoking, and planning. you're not going to even get past the engagement phase if you manage to put your patients off or manage to make them a little bit less likely to listen to you. So it's really about that engagement phase, which is such an important step in the process of motivational interviewing and in the process of behavior change. So what we're going to do here, we're going to try to describe 3 ways that weight stigma can be manifested. We're going to describe the components of what a supportive office environment that avoids weight stigma might look like. And we're going to also help you try to explain how patient-first language can help you avoid weight stigma with your patients. So what does weight stigma really look like? You know, I always hesitate when I'm talking with families and patients about my own personal weight loss journey. But it really was something for me as a child who struggled with my weight from a very early age. It really manifests itself in bullying. And it's a little bit of, you know, being ostracized because you look different or different from other kids. And it really starts very early. You know, I think kids, we used to say, oh, it's probably 2nd or 3rd grade. I really honestly think kids start perceiving each other as being different really in those late preschool years, 4 and 5. It can look like many different things. It can look like, you know, it's certainly, you know, sort of the classic bullying, but it can also just be exclusion. For those of us who, you know, remember being picked last on the kickball team, a lot of things can manifest itself. It's shockingly prevalent. What we find is in most of the studies, and I do a lot of work in bullying, both with kids with weight issues, but also kids, LGBT kids. We really think that probably weight exceeds that and exceeds bullying over special needs, over disabilities, all sorts of things. So it really seems very, very prevalent. It's estimated of kids who are either overweight or obese that the numbers are like 60 to 70% report being bullied. I do think that it is, you know, it's a great question when we're asking our children who have overweight or have obesity, are they being bullied? And a lot of times they're not honest about it, but a lot of times they are, and I think it is quite prevalent, more prevalent than I think we even imagine that it is. But what does it look like in other places, too? Because I think we're doing this on a subtle and sometimes not so subtle level, even as parents and educators. Kids with weight issues, kids with overweight, kids with obesity, report a lot of being bullied by their pediatricians or their parents and educators. And you think, really? I've never really thought that I've ever quite bullied or quite really sort of discriminated against my overweight patients. And then you start thinking about some things that you do. And sometimes they're subtle, sometimes they're not so subtle. I still remain, like, I just can't even believe at one point that I did early in my obesity treatment career, I had a child sit there and I had him take off his shirt while I did his exam. And I thought, you know what, afterwards I was like, I don't know what I was really thinking. Was I trying to make a point to him? He was being shy, not wanting to take off his shirt, and I had him do it. I'm like, I don't exactly know what possessed me to do that. If I was trying to motivate him or, like I said, I'm not sure exactly what my motivation was with him. But I think there are times that we, you know, that we sometimes through cajoling or trying to force the issue, patients can feel kind of badgered. And it can sneak up on you pretty quickly. Sometimes it's the reverse. It's like, you know, we don't expect, you know, we think that a patient with obesity or overweight is not athletic. You know, we'll make assumptions like, well, I'm sure you're kind of, you know, not on the soccer team, or you're not, you know, that running must not be fun for you. You know, we really make assumptions pretty quickly by looking at body types, and we need to get away from it. Patients and children really report this later in, you know, when they talk about their experiences with parents and educators. If you're a child with overweight or obesity, is oftentimes not very positive. I think it comes from a place of concern and honestly from a place of love with parents, but kids will often interpret it as being a little bit more than they really are wanting. So I think, even though it comes from a place of love, sometimes it is interpreted not in that way at all. What does it look like in the media? Well, I think we know what it looks like. There are stereotypes on every show of the person with the weight issue, the person with the obesity is a lazy person, or sort of the cut up, or the person that, never has a date, or, the media is filled with this stuff. And we really need to work at, kind of trying to reel that in. It's really an unfortunate circumstance, and it really perpetuates to this day. Rarely is the leading character someone with obesity or someone with overweight. In healthcare, again, I kind of touched on it a bit. It can be negative attitudes, but it can also be things like furniture, seats that are not big enough, inadvertently or poorly chosen words that we use, our lack of training around how to talk with patients with overweight or obesity. A recent example for us, for a long time, we've had scales that we only had one scale that was able to weigh our patients who were over 250 pounds. So, we had to say, well, it was very uncomfortable. We'd say, well, this scale is not going to work for you. We're going to need to take you over here to the bigger scale. Obviously, we wouldn't say it like that, but, patients pick up on that, or being weighed in a place where it's in clear view of other people. So I think that it's just, we need to be careful of our spaces. We need to be careful of what we're saying and how things are set up. In some places, when I was working in the bariatric, the surgery division at Children's in Cincinnati, one of the campaigns that we were always on was we at Children's Hospital, we often had wall-mounted toilets, and those have weight limits. Those are things that, it's very embarrassing for a patient to say, like, okay, we can't use this bathroom because you might break the plumbing fixtures in here. We have to be careful about physical environment. So why should we bother about this? I mean, this is not just about feel-good kind of stuff. This is really weight bias, weight stigma, has an impact, has a toll on emotional and psychological health. And we all know if we're trying to deal with other emotional or psychological issues, weight management issues get pushed back further. We know that patients who experience weight stigma have lower academic achievement than if they're in a supportive environment. Social interactions are impaired. And really, when we get down to it, it affects eating behaviors. It affects physical activity because you're not comfortable being out there if you feel like you're going to get weight shamed. And ultimately, it affects obesity itself. So our ability to alter those behaviors that lead up to obesity and our ability to affect obesity in and of itself is impeded by our weight stigma that we may impose on people, or the weight stigma that not that we're necessarily imposing, but the weight stigma that our patients are experiencing. So is it time to give up on this? Well, clearly not. That's why I'm talking about it. I think there are definitely some things that we can do. So what are some of those things? I think it's important to make sure, we talked a little bit about making a welcoming environment, but let's drill down into it a little bit more. Office environments should be comfortable and have positive health messages. I think we've seen, those sort of, again, well-intentioned but poorly conceived public campaigns where, a person with overweight, a person with obesity is sitting on a couch watching television with a bag of chips next to them. That was a campaign that came out here in Cincinnati years and years ago. So that really misses the mark. Those kind of messages really reinforce stuff. And I know that we don't do that in our marketing around our offices, but I think sometimes you can subtly get into that and not even realize it's happened because we get so concerned and worried about our patients. We want to have sort of catch their attention, but we really need to stick to those positive messages. An informed, understanding, and respectful staff is critical. A lot of us have heard different stories of people making a comment, and trust me, as a person with a weight issue, you are very alert to people making a comment about you, particularly if you feel like you had to walk across the office because something that wouldn't accept your weight is on that side in terms of a scale or a bathroom or a chair. Role modeling is important. I really pride myself on not being the cookie Nazi in the office, and in fact, I happened to bring in donuts this morning because it was a special occasion in our office. However, I will say that it is important to make sure that we do role modeling for our staff, and that our patients actually see that. That means sometimes too not having suckers or lollipops, but promoting things that really promote more healthy nutrition and activity as best we can. It's good to have a policy. Just express it with your staff about weight bias, weight stigma, so that they're not unwittingly doing the same things. It's all engaging your entire staff in a team approach is essential. Do we have posters of healthy and active living? Again, I mentioned candy as a reward. Do you have TV in your waiting room? Do you have appropriate furniture and exam equipment? Is your weight and height area private and staff trained to be discreet with regard to weighing and measuring patients? I'd like to, at this point, pull out a resource for you. This is from the Rudd Center, and if you notice the policy statement that I circulated to you through Renee is from Rebecca Poole. Rebecca runs the Rudd Center at University of Connecticut, and she's fantastic. This is when the Rudd Center was cited at Yale. It's now cited at UConn. But if you go to ruddcenter.org, you will find a huge number of checklists, ideas, things that you can kind of look through and figure out, like, what messages am I subtly or not so subtly giving to my patients with obesity and with overweight? This are some pictures of some of our 5210 messaging in our office that we've used. We just kind of make it our own, but certainly what we're trying to do as best we can is promote positive messaging. Our one in our exam room, we try to promote someone who's being active. This came from an improvement collaborative from one of our sister practices here in town, and they developed this graphic, which we think is terrific. So what is weight bias's connection and motivational interviewing? I really think it speaks to patient-centeredness. It doesn't really assume anything about our patients. It kind of gives them the benefit of the doubt. It meets them where they are, and it really avoids that unnecessary confrontation. And trust me, it gives subtle messages that you want to collaborate with them. If you're someone with a weight problem, you know when someone without a weight problem is kind of disrespecting you. You know what that looks like. And conversely, you know it when somebody is sensitive to it. It goes a long way. It's important to really make sure you can take some specific steps with your patients, letting them know that you understand that this is not simple. You know, they've heard all their life, all you got to do is exercise more and eat less. Acknowledging that it's hard is a huge first step, and it's an important one. You also want to acknowledge the effort that they've made. If you have struggled with your whole life, chances are this is not your first time to try to address weight issues. You want to talk with them positively about what they've tried, what's been successful, what's not been successful, but just an acknowledgement that they're working for this is important. Be aware that they may have had very negative experiences with healthcare in the past, and that is probably more the norm than the exception. You want to explore all causes for their presenting problems to you in the office, in addition to their weight. You don't want to avoid the topic, but you also don't want to make it the sole purpose. If you think there are other causes for their shortness of breath or their back pain other than excess weight, you got to make sure that you're really looking for those things. They need to know that you're thinking about those things. Even if you are really convinced that this is a weight-related issue, you need to make an effort so that they know you're thinking about everything. Focus on the importance of outcomes rather than weight. For those of you who do weight management in your office on a regular basis, that is something that we have those patients, and kids are moving targets. They're growing while you're trying to get them to a healthier weight. Sometimes they don't lose weight, but they've adopted positive behaviors. Focus on the positive. Let patients know that you realize it's sort of like the first one. Let them know that this is tough. It's going to be difficult. Relapse is more the rule than the exception, and you have to celebrate small victories. I really think, one of the things about, the issue with motivational interviewing is you're trying to affirm, even if you're having a hard time making the overall needle move on BMI or weight status, sometimes it takes a while to get the things moving in the right direction before you'll see that be affected. Weight is a really tough outcome. It's really tough on a population basis to see it. It's really tough on an individual basis too. Sometimes, if you're healthier and following healthier habits and your weight doesn't change, that's still a victory. So I mentioned the Rudd Center. What are these images? What can they look like? Well, it doesn't mean that you just put thin people in your images. It means that you put people with obesity, people with overweight, doing things that we all do and things that are not associated with those negative stereotypes. So these are representative images from the Rudd Center, and these are all available to you if you go to ruddcenter.org, and you're able to download these. So if you have office materials that you need, you can't use these for marketing, obviously, but if you have pictures that you need to use, I encourage you to go to the Rudd Center. There's even pictures, there's even some videos and some other items that are positive images of people with overweight, people with obesity, that are not, sitting on the couch or not sitting in front of a double-decker hamburger. So I think, these images are not easy to find. The Rudd Center is great at keeping these together for us. What's the staff for the work for your staff? I think it's important to talk about it with them. I think it's important to talk about, what kind of language are we going to use with our families? Our MAs and our RNs, when they're checking our patients in, they're going to get questions about weight, like, is this weight okay? I'm afraid he's gaining too much weight. It's good to have a discussion as an office about what kind of terms you're going to use. It does appear and there's a little bit of conflicting data on this, and I have to confess that part of the conflict comes in from some work that we've done around focus groups that I was part of. But parents in general don't like the word obesity. It's a clinical word, and if you're going to use it, you're going to want to put it in context, why you're saying that. Is it something on their on the growth chart? What is it that makes you want to use that diagnosis? So you have to put it in context for them. But you want to figure out what kind of words you're going to use and what kind of words do work. I put some other ideas down here. Not all of them feel right. I'll be very honest. Not all of them all feel right to me. I have to figure out with the family what kind of words we're going to use. And I sometimes dance around it a little bit. But I think you have to figure out words that work for you and work for your families. It's also culturally very different for different people. So I throw this out not as saying use this word, use that word, but be alert to it. You're going to find certain words that fall flat, other words that do better. I do a lot of reviewing of papers in this area, and sometimes I think I come away from it more confused than before I start reviewing an article on it. Because one of the ones I can give this as an example. I was reviewing an article, and one of the favored words was the word chunky. I'm like, really? I really didn't expect that to be a favored word, but it was a favored word for a small group of patients, like it was a group of boys who were in the 95th to 97, so they didn't have severe obesity, and they were all white. So it's like, okay, there are words that are going to surprise you. I think sometimes the studies are just not there to say, there are not enough kids that have participated in this to be able to say this is a good word, this is a bad word. I just ask you to think about what you're using and see what kind of responses you get. One language thing that I think is very important is to use patient-first language. So, if you look in the medical literature even from the 1970s, we used to refer, this is a study that's been done, that 90% of the time people refer to a patient with cancer as being a cancer patient, or a patient with hypertension as a hypertensive patient, or a diabetic patient. We really got away from that in the 70s and 80s. And by the 2010s, the numbers had reversed. 90% of the time, we would say a patient with diabetes, a patient with hypertension. Well, guess what? That has not changed for overweight and obesity. We still refer to patients as an overweight patient or as an obese patient. For some reason, we view those as adjectives more than we do disease states. And again, it makes a difference. It's sort of like it almost defines you as a person. So obesity is one aspect of what your health milieu is. It is not a definition of who you are. So I would encourage you to really think about using terms like a patient with obesity or patient with overweight as opposed to an obese patient or an overweight patient. You wouldn't believe how many times even in the obesity literature we're still doing it. And I still catch myself with it constantly. So what are the highlights of the AAP policy that we provided to you? Well, I think there are some things. I don't mean to just keep beating a dead horse here, but when we talk about they're sort of in two categories: improving clinical practice and advocating against weight stigma. So what can we do for improving clinical practice? Sort of mentioned it. It's role modeling. It's language and word choice. It's clinical documentation and the words we used for that. It's the clinical environment you set. It's knowing some of the skills of motivational interviewing and behavioral change counseling. And it's also doing some behavioral health screening. Looking for those patients, and what I mean by that is, patients that have experienced weight stigma. Patients who have experienced weight stigma often have other behavioral health issues like depression, anxiety because of it. The other thing, when we talk about advocating against weight stigma, we think that there's room to improvement to be made in schools. Certainly, the media that targets youth needs to be very aware of it. We think that there's need for provider training, and by provider training, I also mean everybody in your office. And I think there's help that we can provide to parents so they're not weight shaming their own kids and really doing the very opposite of what parents are wanting to be doing. Everybody's got a role in this in your office. Consistent language and approach is essential. Patient-friendly scheduling for follow-up for weight management visits, and being able to make an office setting that is conducive for you to help your patients is all very important. It's really a golden opportunity, with performance improvement initiatives like PMP. It's also helpful if you're going for PCMH certification. There are plenty of places you can demonstrate improvement. And I really think, a lot of when we consider that 2/3 of Ohioans and 2/3 of adults across the country have either overweight or obesity. You'll be amazed how many times your staff is energized by this, and they'll come back with stories saying, you know what, I've been on the receiving end of this my whole life. I'm really glad we're addressing this because I felt it personally. So with that, I'd like to open up for any questions if anyone has any.